0 COVID patients on the ward. So it's been an unprecedented year. It's been a year of heartache, but also hardship, but also discovery. And I think webinars like the MUNA Association's webinars has been a welcome development for us to share our learnings and our experiences across the globe. So to start with, I'm going to give a brief clinical vignette scattered with some of the lessons we've learned over the last year and talk about some non-pharmacological aspects to how we manage these patients and some thoughts about what the future might hold before passing it on to Charlotte and Kim. So the case is a 44-year-old lady who was admitted on the 8th of February. She had tested COVID-19 swab positive in the community, and she'd been looked after by the oximetry at home team. So the oximetry at home team in the UK is when patients are tested positive, have mild symptoms, but mild enough not to require hospital admission, the GP or primary cares will give them an oximeter and monitor them with the flexibility that if the patient deteriorates, they can be escalated to the emergency department and be admitted. And that's exactly what happened to this patient, that she managed to plod along for a few days and then eventually about into the second week, which is the classical nadir we start seeing is the second week when they get hit, if they are going to get hit. And she presented with 1 day's history of worsening breathlessness, worse on exertion, and a temperature of 37.9 for the last day. She has a past medical history of hypertension, anxious, polycystic ovarian syndrome, colitis. Her echo from the previous year hadn't been brilliant, and she was overweight and had an impaired glucose tolerance. But she was only taking amlodipine. So on assessment, she was febrile. Her respiratory rate was not that bad, and her saturations were actually holding on room air, and her chest just revealed a few crackles at both bases. So in this situation, the differential diagnosis, and it's really important to keep your horizons open because other things can masquerade as COVID-19, and it's very easy to assume that anything that comes in with respiratory symptoms is COVID-19. So we use the basket term lower respiratory tract infection, and obviously top of the list, yes, is it COVID-19, especially with having tested positive a week prior. But you have to think about other viral pneumonias, especially in wintertime in the UK. We have our fair share of rhinoviruses and arenavirus and adenoviruses. Bacterial pneumonias are not uncommon, and also thinking about HIV and Pneumocystis jirovecii, which can also present in these patients as well. So on the day of admission, this is her X-ray, and just to describe it, you can see she's got bilateral, but predominantly on the right side, patchy infiltration. So predominantly in the right upper and right mid zone, but there's also some involvement in the right lower zone and some sparser involvement in the left mid and the left lower zone possibly as well. So there's definitely fluffy, patchy infiltrates bilaterally, more on the right than on the left. Her blood gas showed that her PO2 was reduced at 8.6 on 2 liters. Now, for a 44-year-old lady who's otherwise well with healthy lungs, this is disproportionately low. Her full blood count was normal, but her lymphocytes were indeed reduced at 0.6. Her CRP was elevated, creatinine was normal, and we confirmed by repeating her PCR test that her COVID status was positive. So these are her set of OBS as she came in, and then just to show you that on initial presentation, she was being managed quite comfortably on 1 liter, but then gradually that started increasing. So her oxygen requirements are going up, which is enabling us to maintain her saturations. Then she gets switched to a Venturi mask, and you can see her oxygen requirements going up from 35% to 40%. So by the 11th to the 12th, she's now requiring humidified oxygen. And on the 12th of February, she was put onto Optiflow because her respiratory rate went up and her oxygen levels went down. So what we can clearly see is that her oxygen requirement was going up in the matter of 3 to 4 days. And when we repeated the X-ray on the 11th of February, you can clearly see that this is more widespread, patchy infiltration, actually looking more confluent now on the right. And the left side is definitely more involved. And she's probably just breathing on this left upper lung portion that's not been as badly affected as the rest of the lung. And that explains why she's short of breath. And this would fit into the definition of acute lung injury and adult respiratory distress syndrome. So on day 4, her new score is getting worse. We put out a MET call and she gets transferred to the respiratory support unit. So there's very good evidence that low molecular weight heparin subcut BD is being shown to be beneficial. There's been mixed evidence regarding the role of therapeutic low molecular weight heparins. The evidence as of this moment in time is that therapeutic low molecular weight heparin in patients who are severely ill and on requiring AGP or intubated actually is deleterious. But there is some evidence showing that therapeutic low molecular weight heparins in the moderately unwell patient is therapeutically efficacious. Again, the definition of moderate and severe we can talk about, but it does vary. We started her on steroids, dexamethasone 6 milligrams BD, and we ended up giving her Optiflow or high flow nasal cannula oxygen. And on the 11th at 6:30 p.m., we gave her tocilizumab, about which I'll be talking about as we go through the presentation. So she received the tocilizumab, and we can see that within 48 hours, she was able to come off the high flow nasal cannula. And then with the subsequent 48 hours, she was down to 1 liter of oxygen. And all told, she spent 4 days on the respiratory support unit, and we actually discharged her from the RSU. So she only spent 7 days in hospital. Now, this is our current management plan, and it's in contrast to what we were offering our patients in the first wave or even at the tail end of last year. And that's been a journey of discovery, as I alluded to at the beginning of this talk. So just to show you, her lymphocytes, you can see they were stuck below 0.9 for a good long while. Her LDH had spiked, but then it was coming down. Her CRP over the course of her illness also improved, and her ferritin again spiked when she was very poorly. So on the 12th, you remember she had received the tocilizumab the day before, and then on subsequent checking, it had plummeted back down to within normal range as well. So very briefly, I just want to talk about a few lessons that we've learned that I've alluded to. So we think we're beginning to understand the pathology and the natural history of COVID-19, where we have those patients who are still at home, who are probably in the viral response phase. They may or may not have symptoms. And if they do have symptoms, they tend to generally be the prodromal, the aches and pains, the flu-like symptoms, the cough, and just feeling unwell, the malaise, etc. Usually it's around week 2 that they will, if they will get the pulmonary phase. And what we don't fully understand is why some patients do develop pulmonary involvement and other patients don't. But it's usually around the week 2, and that fits exactly with this patient. She presented on day 8 to 10 of onset of symptoms. And then there's this cytokine storm that we keep talking about, which is, in other words, the host inflammatory response phase that we've also recognized, and in some patients they continue to deteriorate despite everything we do, and they do die. As of today, we can see there's been 121 million confirmed cases and 2.68 million deaths globally. And though predominantly it's a Western Hemisphere illness, we do recognize that the numbers in Southeast Asia have been increasing of late as well. I just want to briefly talk a bit more about COVID-19. We recognize that the majority of patients are asymptomatic. We recognize that another majority of patients will have mild symptoms. By that, I mean that they have practically no respiratory involvement or very mild respiratory involvement with or without chest X-ray changes, but without any physiological consequences. About 14% of these will deteriorate and will show X-ray changes involving more than 50% of the lungs. And it generally tends to be a very aggressive development happening in hours to days. And then a certain percentage of these will develop respiratory failure, shock, and multi-organ failure. And overall, with the denominator of total cases, the fatality rate is around 2.3%. But obviously in hospitals, we're seeing a select cohort of patients. And in this registry from New York, we can see that a quarter of patients died. A quarter of patients ended up on ITU, which were obviously the sickest cohort within that group. And of those, more than half died. And that number hasn't really changed significantly over the last year that we've been dealing with this case. This is just a reminder that COVID-19 does affect other organs. Just to share with you, we saw more neurological and GI involvement in the first wave. We saw more hepatic involvement in the second wave. Whether that is due to an evolution of the COVID-19, whether that is patient selection, or whether that is due to the different strains. And we've all heard about the Kent strain and the Brazilian strain and the South African strain. So it's difficult to be definitive about what the explanation is for this changing phenotype of COVID-19. But the other thing to remember is that COVID-19 affects the skin, the GI tract, the endocrine, and the systemic inflammation does have systemic effects as well. We fortunately didn't see a tremendous amount about cardiac involvement, but we did see our fair share of prothrombotic state and thromboembolism in these patients as well. So alongside our management plan is how we monitor these patients and the role of labs. I've talked about low molecular weight heparin and the role of prophylactic, but what we call intermediate dose prophylactic doses and therapeutic. Steroids has become the mainstay of treatment, and I'll be talking a bit more about tocilizumab and a bit about controlled oxygen. So labs, we have a routine in which we do daily labs, and normally that includes the standard labs, but also CRP and ferritin. If the patient has a coagulopathy, we will do alternate days, PT, APT, fibrinogen, and D-dimers. And also, if required, we will do LDH and troponin as well. We also use a lot of procalcitonin to help identify, because the steroids and the tocilizumab are immunosuppressive, having a normal procalcitonin, which is a marker of infection, is really helpful for us to decide whether or not to administer these drugs as well. So the evidence for dexamethasone came from the recovery trial, which is a multinational trial in which patients were randomized to receive standard care or one of 4 drugs to begin with, but it's evolved over the last year. One of the first drugs that was included in the arm was dexamethasone, alongside hydroxychloroquine, azithromycin, and Kaletra. And we were fortunate that relatively early on, we found that dexamethasone actually improves mortality. So if you compare the group that received dexamethasone in red versus those who received standard care in black, there is a statistical difference and a reduction in mortality in those patients who received dexamethasone. If you divide this into those patients who do not require oxygen, and that group of patients who require oxygen alone, or those patients who are on some form of aerosol generating procedure like Optiflow, CPAP, or being ventilated or on ECMO, what you can clearly see is in the group who does not require oxygen, there is no statistical improvement in mortality if they receive steroids. However, in that group that requires oxygen, or those patients who are requiring higher forms of ventilatory support, the benefit is incremental, i.e. that the statistical reduction, the reduction in mortality is statistically more significant in these cohorts of patients. So if you don't have dexamethasone, there are alternative steroids that we can use. And we did for a while adopt a step up policy in managing these patients, that if they were not responding to low dose steroids, we were doubling it, we were flipping to methylprednisolone, and we were using high dose methylprednisolone. And this we used for several months with variable success until tocilizumab came up. And for us, tocilizumab was a game changer. Now, tocilizumab is an anti-IL-6 drug. It's used for rheumatoid arthritis and for treating lymphomas, and was initially in the REMAP-CAP trial and the COVACTA trials, and then eventually the recovery also included this as a second arm in their randomization. So what the interleukin 6 does is it causes an inflammatory storm, and what tocilizumab does, it blocks the interleukin 6 from binding onto the receptors and thus prevents the cytokine storm. The dose is weight-based, but for just simple memory, it's 8 milligrams per kilogram body weight. The recovery trial recommended 2 doses 24 hours apart, but the REMAP-CAP trial and the other trials showed that we got away with 1 dose, single dose administration. So in the recovery trial, tocilizumab was used in patients who were on oxygen with a high CRP of above 75 and within 21 days of starting treatment. And they were randomized into the first arm, which was, as I said, steroids or hydroxychloroquine or azithromycin or Coletra, which is the antiretroviral drugs. And if they still had raised CRP, then they were randomized to receive or not receive tocilizumab. And as you can see, the groups that received tocilizumab versus the usual care, there was no statistical difference in these cohorts. And what we can clearly see is that there is a statistical significant reduction in mortality in the group receiving tocilizumab versus usual care. If you stack up the evidence for tocilizumab versus all the other trials, including COVACTA and REMAP-CAP, you can see that apart from REMAP-CAP, all the others did not show a statistical significant improvement in the use of tocilizumab, but recovery confirmed this. So in summary, if we were to today have a patient who's symptomatic with low oxygen levels, who have abnormal imaging, whose COVID swab is positive, we would offer and we would administer dexamethasone or steroids to these patients, and we would also give them tocilizumab. If we have a patient who's symptomatic, predominantly with low oxygen levels, but whose imaging is normal and their COVID swab is positive, again, we would again prescribe them dexamethasone and tocilizumab. It becomes a bit more murky where you have a symptomatic patient whose X-ray may be normal or abnormal, but their COVID swab is negative. And we've been on a roller coaster with false positivities and false negativities as well. And at this point, I think the conclusion is it relies on your clinical judgment, that if you think this patient is presenting with type 1 respiratory failure with or without an abnormal X-ray and with a negative COVID swab, if the differential diagnosis is COVID-19, then indeed we would offer this patient dexamethasone and tocilizumab because the benefits outweigh the risks in this patient. However, if a patient is asymptomatic, regardless of whether their X-ray is normal or abnormal, and regardless of whether their COVID swab is positive or negative, we would not recommend giving them dexamethasone or tocilizumab because actually there is no evidence that these patients benefit from either steroids or anti-IL-6. So recovery trial is still ongoing, and currently patients are being randomized to receive colchicine or antithromboembolic therapy with aspirin or antibody-based therapy or early immunomodulation with baricitinib versus usual care alone. And we still await the outcomes for these trials. But I think we're in the fortunate position now that our number of COVID cases has dropped so significantly that I think it's been, and Charlotte will know this more better than I think it's been a few days since we've recruited anyone into the recovery trial. And I think our numbers have really dropped off significantly over the last 1 month. I want to briefly touch upon non-pharmacological approach, which is my segue to Kim's and Charlotte's talk. I think it's really helpful to start thinking about when you see these patients coming in, how can you stratify which patients are going to do better and which patients are going to do worse? The severity of organ dysfunction, by that I mean how bad is their respiratory failure, or how many organs are affected is a predicator of how poorly or how well they'll do. We recognize some features which are associated with more severe illness, and normally these are the blood tests. And patients with more comorbidities, so increased BMI, as well as being diabetic and hypertensive. And also those patients who've got hematological malignancies, we know that these patients tend to do more poorly. Patients who are older, we know there's very good evidence that these tend to do more poorly, and this is the UK evidence that you can see the majority of our deaths were patients aged 60 and above. But we also recognize that patients belonging to poorer socioeconomic status, we know that there's a male predominance, and lab abnormalities. We know that those patients who've got more markers of deranged ferritin, LDH, and D-dimer, these are poor prognostic markers, and we do use these as adjuncts to help stratify our pharmacological markers. We recognize there are some viral factors, and this is where the strains might come in. And we also recognize there's some genetic factors. For example, in the first wave, we know the BAME population were more severely affected. But we also know it's like certain populations, like the Irish population, are more protected. We don't fully understand this. I'm sure Kim and Charlotte will be talking more about respiratory support, but we have a couple of options when we're dealing with these patients to escalate their care from controlled oxygen to high flow nasal oxygen to CPAP. We have not used any BiPAP in these patients, but as some of these patients who have developed multiple comorbidities, obesity, hyperventilation syndrome, bit of COPD, and the CO2 starts rising, that I can envision a scenario where this could be used, and also intubation and ventilation as well. I think where you look after these patients is really important, and our system was inundated, and we were looking after these patients on level 0 wards, which is a normal ward with the normal nurse to patient ratio, whereas I think other hospitals which have got a larger number of ITU beds, and so they were looking after these on level 2 and level 3 beds. The British Thoracic Society came up with a very pragmatic advice on how to manage these patients. And in essence, the advice was that if the system has not been overwhelmed, these patients who are requiring CPAP or Optiflow should be managed on the intensive care unit. However, in war footings, they can be managed on the wards provided it's safe, monitored, and they have the appropriate number of senior clinicians as well as the other healthcare professionals like physiotherapists as well. We came up with this strategy that we would start them on oxygen. If they were deteriorating, we would put them onto high flow nasal oxygen. If, however, they continue to deteriorate and they required CPAP, that would be our trigger for escalating them to ITU if they were on CPAP for more than 12 to 24 hours, provided they were suitable candidates for escalation to ITU. Obviously, you can appreciate elderly patients with multiple comorbidities, poor performance status. You could argue that in certain cases like these, escalation to ITU would be futile. There's very good evidence about multidisciplinary team working in managing these patients, having board rounds and huddles, as well as case discussions with external agencies. And we were daily discussing these cases on the respiratory ward and the respiratory support unit with our intensive care colleagues. And we found that really helpful and supportive way of approaching these patients. So I just want to share a few more thoughts about what the future might hold. In October 2020, as we had come out of the first wave, everyone was predicting that we would get a second wave, but it would be less severe, probably about half of what we got in the first wave. Whereas the reality was it was about 2/3 worse than what we got hit in the first phase. And the modeling does suggest that we are on track for a third wave in the UK somewhere around mid-July or early July. And therefore, I think we need to be thinking about how we arrange our services and our pathways so that as the number of COVID cases increase, we can ramp down our elective work and escalate our inpatient services. And as the cases subside, we can ramp up our elective work and refocus our energies and resources into managing these patients as well. Another challenge that we're going to be coming up is the follow-up of these patients who have been hospitalized with severe COVID pneumonia, being managed on ITU or respiratory wards for days, weeks, even months. And what are the long-term sequelae from a respiratory point of view, but also what are the long-term sequelae from a non-respiratory point of view as well. And I think there's a question about all those patients who did not have COVID-19, but had other health conditions whose care has been impacted by the diversion of resources to managing this pandemic. And these are questions that we just don't have the answer for. We're beginning to understand more and more about long COVID. We understand that there might be some organic dysfunction and sequelae, but we also understand there might be some psychological post-traumatic stress disorder and other sequelae that we are yet to recognize, and the impact upon social and psychological well-being is a big question. And we expect that we're not talking about days, but we're talking about weeks and months to come, that we will begin to understand these things more, and therefore we can direct our resources more. So I'm going to stop here. We've already said we're going to take questions at the end, and I'll stop sharing my slide.
Thank you very much, Khan. It was extremely informative. Before I call upon Kim to give us her presentation, I just wanted to just quickly inform everybody that this session is being recorded. So for anybody who's camera shy, you're welcome to turn off your cameras. And once again, if you don't want to ask a question at the end, please feel free to type it in the chat. If you don't want people to know it's you asking the question, you can directly send the message to me or to Charity, as you can see in the chat. Another small ask is, because we would like to know who you are, it would be nice if you just pop down your name, say where you're from. And I think my fellow colleagues from Malawi have done that extremely well. So thank you. It's good to know that we've got people who are in Malawi who have joined us on the webinar today. And just to clarify, I do appreciate that we have people who do not come from a medical background. So some of the things that are being discussed might be a bit too scientific or too nursey or too medical. Please do put it in the chat if you have a question. So if it's anything like, what do you mean by CRP? Because I noticed that Dr. Khan talked a lot about CRP levels. Pop it in the chat. And CRP, just for your information, is just an inflammatory marker. What we look for is CRP tends to is produced within your liver. So we pick that up when we're doing your labs. And if the numbers are high, it shows us there's some sort of inflammation within your body. That's why Dr. Khan kept talking about the CRP, which is one of the key areas that we look at. So Kim, I'm going to pass that on across to you now with regards to nursing management of COVID-19. Whenever you're ready.
Sorry, I was just trying to figure out how to get my voice unmuted. Can you see my screen and hear me?
I can hear you, Kim, but your screen, we're just waiting for you to start sharing your screen. It's logging, so it's just taking a little time to load. Are you all right to introduce yourself whilst that's waiting to load, Kim?
Yeah, of course. So my name's Kim. I'm a registered nurse. I have been for about 1.5 years now. I was a mere 6 months qualified when the pandemic hit, so understandably quite a scary time. But thankfully, I work as a part of a really good team, so we all bounced off each other and made it work. So this is my first time to present on a Zoom call or a webinar, so bear with me.
No, fantastic. I'm barely 1 year qualified as well, so I work in critical care. So we're in the same boat. I think with what COVID has done to all of us, because it's something new, we're all learning.
Definitely.
And I think that's what this platform is trying to do, is that we learn from one another, learn from our experiences as clinicians, and we learn from our colleagues with their lived experiences, so that we can share good practice. So yes, you're more than welcome to a Muna platform. Your screen is still frozen. I can't see anything, Kim. Are you able to see anything on your end?
Yeah, it does say I'm screen sharing.
Okay.
I don't know what you did last time. When you can you try putting your camera on and do this again, because it worked last time.
1 second. Whoop.
All right, because we've got a quiet lull in there. If there was a question whilst we're waiting for Kim to sort the technical issues, if anybody's brave enough to ask a question. No? Okay, I do know that we have a lot of questions around vaccines, so we're not putting that off the table. We will take any and every question that comes at the end. I think because this is what's happening in the current environment. So with COVID and management and vaccines, they all go hand in hand. So do not feel that you can't ask a question around vaccines. Ask, and we will try our best to try and get an appropriate answer, or we will always give you a disclaimer to let you know that these are opinions that are coming through.
Are we still having no luck, Salah?
No luck, Kim. Okay, Kim, are you able to email it to Charity? And then we'll try and get Charity.
Charlotte's got it, I think.
I emailed Kim's and Charlotte's presentations to both you and Charity. So you put the presentations.
Okay.
So we can
Check your emails.
Okay, so Sarah, are you able to share it, please?
Yep, let me learn how to multitask.
Okay. Sorry for that.
Sorry for that, everybody. This is technology and hiccups. Right, whilst we're trying to sort this out, can I ask, Charlotte, we might have to swap over. Charlotte, here, do you have yours ready?
Yeah, I'm free to go now if
Yeah.
yeah.
Kim, do you mind if we let Charlotte go and then we try to sort out the technicalities in the background?
Yep, that's fine.
Yeah, is that all right?
Yep.
Sorry. Yeah. Brilliant. Charlotte, I'll let you take the floor whilst I try and sort out the IT stuff in the back.
Can everyone see
Yeah,
that?
Charlotte, we've got you. Yeah, we've got you.
So I'm
Yeah,
Charlotte.
go ahead. Introduce yourself.
Yeah.
Yeah, so that everybody knows who you are. Thank you.
So I'm Charlotte. I'm one of the respiratory physios at Darren Valley. I've worked at Darren Valley for about 5 years now, and I primarily work on our respiratory ward. So I've been dealing with COVID patients throughout the whole pandemic, both in the community and on the ward. I did a sort of about a year in the hospital home team as well. So I've kind of seen it from both sides, which has kind of been really good at helping me kind of be more holistic on my treatment. So I've prepared a presentation which is really just about the more practical side of the treatment and assessment from a physiotherapy point of view. And yeah, so assessment findings, treatment findings, on-road referrals, and a little bit into long COVID. So on assessment of these patients, we're kind of looking at a multifactorial assessment. We want to be looking at all sorts of areas into their health. So we're looking at the psychological effects of the COVID-19. Primarily, we were finding a lot of anxiety and fear based around the breathlessness, based around the isolation of being on a ward away from family. It was obviously not allowing any visitors into the ward, so we're finding a lot of that was impacting our patients. We're having a lot of post-ITU PTSD, especially now when we're getting the patients that have been on ITU for such a long time. They're coming to the wards as a step down. The respiratory ward is a step down, and they're having a lot of sort of almost post-traumatic stress from that ITU stay. So that's another impact that we're having from a kind of physio point of view. We're also looking into respiratory assessment. We're finding that these patients have quite a high respiratory rate. They're very breathless, complaining of shortness of breath, low saturations, and high oxygen requirements. So there are kind of key findings in that area. On auscultation, for a physio, they're generally sounding quite clear. They're not sort of overwhelmed with secretions. From our point of view, we are finding some reduced air entry sort of in the bases, where the patients aren't mobilizing as much, are kind of sitting down more, lying in bed, that sort of thing. Cough we're finding is generally dry and persistent. The coughs aren't very productive. It's that sort of irritable, dry cough that we're finding. From a functional point of view, mobility is really limited by the breathlessness and the desaturation. And the high amounts of support that these patients are receiving, so the CPAPs and the optiflows, because they're requiring that high support, obviously you can only mobilize them, or functionally you can only get them as far as the lead will allow you especially for the CPAP and the optiflow. So it was just all about looking at this assessment, looking at our findings, and then trying to work with what we had and what work on the impairments, so that we're trying to reduce the impact of that going forward. So I'll start with oxygen weaning. We had a really big kind of involvement with the weaning of this oxygen and weaning of the sort of AGPs and the support on the wards. It's not, in terms of CPAP and optiflow, I'll admit from a physio point of view, before this pandemic, we weren't massively suppose like altering settings for that. We would recommend, and we would kind of do everything else, but predominantly the CPAP and the optiflow we leave to nurses and doctors. So for this, we all had to kind of be really trained up and really kind of just almost just crack on with it, because it got to the point where we were all having to muck in. A lot of we were doing at one point in the pandemic that we were static and part of the nursing establishment on the respiratory ward, so we were there kind of for their shifts, and and we were primarily doing this CPAP and Optiflow weaning. So as with all of it, each stage of the weaning, it's all about weaning the FiO2 as able with each mode of support. The CPAP, you know, they're on the PEEP and they've got the FiO2, so it's about weaning that. And the arrow down this left side is just showing the kind of the weaning down of the support and kind of what we're going, sort of highest level of support that we were seeing on the respiratory ward down to sort of weaning them off of the oxygen altogether. So CPAP's obviously our most supportive, and then we were trying to wean them onto the Optiflow. On the Optiflow, we're finding when we were weaning them, it was really important to wean the FiO2 before the flow. We're finding that the patients actually really required that high flow, and to wean that first was actually not working so well. So we were placing them, weaning the FiO2 before we were weaning the flow. Then we were going, so when we were getting the FiO2 to around 60% and the flow down to about 40 litres, then we were thinking about placing them on the humidified circuits. We were finding that humidified circuits were much more comfortable than the Venturi, because obviously you've got that humidification there, as the Venturi is very dry. When they're requiring quite a lot of oxygen, that much oxygen just to come through quite dry was quite uncomfortable for these patients. So we were finding humidified circuits were much more easily tolerated. Obviously weaning down the FiO2 till we could get onto sort of nasal specs. With the nasal specs, we were looking at weaning. It wasn't just a case of kind of being on it or off it. We were having to think about, you know, what the patient was doing and how we could wean it. So first of all, they were obviously on it all the time, and then we were just using them on the nasal specs just for ambulation, and then we were going to keeping it on overnight, and then we were looking at, you know, trialing 24 hours off it, see how they were going before we were thinking about any sort of discharge. Going on to the breath assist management, so that was like a really big assessment finding that we were having. When we were seeing these patients, they were really limited by that breathlessness, especially on the exertion. Really minimal amounts of exertion were making them really quite breathless. So we were having to go through lots of techniques to try and help that breathlessness. So these were just a few of the things that we were finding were really helping. So we were thinking of the pacing. When we were mobilizing patients, we were really having to like break down the task, stagger the task. So rather than doing like a big session in one go, we were staggering sessions with that patient throughout the day. We're doing blow as you go, so trying to teach these patients as they're walking to almost time their breathing with their walking. So we're saying sort of 2 steps you breathe in, 4 steps you breathe out, and that was really helping pace their breathing as they were walking. We were teaching these patients positions of ease. So in the pictures there, you've got these positions of ease. So when you lean forward onto your forearms and fix your shoulders, you kind of switch the origin and the insertion of the shoulder muscles, and you can use them as accessory breathing muscles just to help you get your breath back quicker. So we were doing a lot of positions of ease, especially sort of after the patient's mobilized, we get them back to the chair and we pop them in a position of ease to recover their breathlessness much quicker. We're teaching a lot of the pursed lip breathing. So when you're breathing in through your nose and breathing out against the pursed lip, so like blowing out like that. Breathing out against the pursed lip is really a good way of creating, you're breathing out against almost a positive pressure, and that's kind of splinting open your airways and helping you get your breath back quicker. Improving exercise tolerance, so making sure that the patients were doing something every day was helping with breath assist, because obviously you have that, you know, that downward spiral of avoiding exertion because you don't want to get breathless, and then because that's obviously an unpleasant symptom, and then that in turn reduces your exercise tolerance, and then when you try and do something, you get in the quicker onset of breathlessness. So just trying to break that cycle of not avoiding doing things because a patient's breathless. Maintaining lung volumes is another big thing that we were trying to do. Obviously, as I said, these patients are way less mobile, they're sitting down or in the bed, and we were really trying to avoid that we were getting the small areas of collapse in the lungs. So we were doing lots of active cycle of breathing with these patients. diagram that you can see here with the arrows, this is just a really simplified version of the breathing exercises that we were teaching these patients. So really the 3 to 4 thoracic expansion exercises are the key ones. So you're taking a deep breath in through your nose and holding that breath for up to 5 seconds, and then breathing out, like I said earlier, against that pursed lip. Breathing control is just your normal tidal breathing, and it's really about, you know, those thoracic expansion exercises, the deep breath in, making sure that the breath is going right down to the bottom of the lungs. You want the tummy going out, really avoiding the breathing with the shoulders going up. We want the tummy to rise. So that's what we're really teaching everyone. We also ordered a lot of incentive spirometers through the second peak. We weren't really using it so much as in the first wave. But the second wave, we ordered a lot of incentive spirometers, and that's this thing down the bottom here, this plastic machine almost. Basically, the patient will take a deep breath in through this tube at the bottom, and you're aiming for this little blue circle on the side to go up and be held between these 2 markers. So if you take a really deep, quick breath in, that will go way up to the top and then back down. Or if you don't take enough of a deep breath in, it will stay at the bottom. You're aiming for the patient to keep this marker in between the arrows for a really long, prolonged, deep breath. You don't want it to be a quick, deep breath in out. You want that prolonged. And then as they take a deep breath in, this bar will come up and show you how many mils they're getting. So, and then as an objective marker, you can slide this up to where they're getting, and you want them to aim it or exceed it. When we were first seeing patients, really, most of them were only able to get it to the sort of 750 marker, which was quite poor. But with this, we were finding that with the positive feedback that they could physically see what they were aiming to achieve, and with the sort of objective markers that they can that they can see on this, we were finding that it was really encouraging them to take deep breaths. It's also something we can leave with the patient, so we don't have to be there with them while they do it. We advise sort of, we say 2 to 3 breaths 10 times a day, because we were finding when they were doing more than 3 breaths in one go, they're getting quite lightheaded. So it was something that they could do in the meantime when they're sat in the chair not doing anything. It's still encouraging them to take those deep breaths. So it was really good, and we had some really good feedback from our patients using that incentive spirometer. Maintaining lung volumes, again, is sitting out and mobility. We really wanted to avoid these patients being in bed for prolonged periods of time. Obviously, when they're really poorly, it's different, but trying to get them sitting out in the chair as soon as we really can is much better. Obviously, when you're more upright, it offloads your abdomen from your lungs, you've got more space for your lungs to expand. And obviously, when you're mobilizing, that encourages you to take those deep breaths. So it was really important to get these patients up and out of bed and upright. One of the biggest things that we were kind of focusing on was our positioning, and primarily our proning, putting patients in a prone position. So anything really avoiding supine, so lying on your back, anything that's avoiding lying on your back is better. Sitting out, being upright, those sort of things. But when someone's in bed, we're encouraging them to be prone. So that's lying on your front. As you can see, this top person here lying on their front. If patients, like a lot of elderly patients, reduced kind of flexibility or mobility, or patients who are really anxious, sometimes weren't tolerating this position. So we were kind of doing a 3/4 side lying, where they're sort of lying, their chest is kind of on their front, but their hips and their legs up more on the side lying. So it's that 3/4 turn, because that's better than not doing it. Or side lying if they couldn't tolerate that. We're looking for position rotation and changes. So, you know, trying to sit up in the chair for a little bit. When you're in bed, trying to be on left side for a bit, right side for a bit, and on your front. But we were really encouraging this prone position for our patients. So the importance of being in prone, so lying on your front, is it improves VQ matching. When you're lying on your front, it offloads the heart and abdomen from the lungs. It has been shown to improve heart function. Again, also because you're lying on your front, your lungs are falling against the more curved part of your ribs, and not the more flat fixed posterior ribs, which is when you're lying on your back, your lungs will fall against those flat fixed posterior ribs, which doesn't allow for as much lung expansion. Obviously, secretion clearance we weren't finding was a massive issue with these patients, but also being in prone does help with sort of draining of secretions. if that was an issue that needed. So proning really was important for these patients. Mobility in the rehab side of things. So maintaining mobility primarily is really important, especially for our younger patients, the patients we wouldn't normally be picking up on the ward for a mobility assessment because they're normally independent. We were finding that we were still seeing everyone, regardless of whether they were independently mobile, because we wanted to maintain that mobility. You know, if they're stuck on the oxygen or stuck on CPAP, Optiflow, there's not that much opportunity for them to be walking around. We were finding if we were going around to these patients, we were giving them that opportunity to maintain their ability. Obviously, plus or minus aids, if they were needing any physical support, we could provide that. And also monitoring their SAT. So obviously these patients are really suffering from desaturation. When we're mobilizing them, we're able to, you know, put a portable SATs probe on them and have a look what's happening to the SATs when they are mobilizing. Again, as I said, you know, these patients primarily on oxygen or on support, so didn't provide them with lots of opportunity to be mobilizing. So we were, you know, coming around to these patients with portable oxygen cylinders and putting them on a venturi to mobilize. If someone was on sort of say 60% of Optiflow, we were able, or humidified face mask, we were able to put them on a 60% venturi and mobilize them on that. Just so that they could kind of mobilize away from the bed space. Obviously the Optiflow is stuck to being plugged in the wall, so it doesn't provide that opportunity for mobilization. So coming over with the venturi and the portable oxygen really did provide that patient the chance to maintain their ability to increase their exercise tolerance. And also it's just really good for us to know, you know, how much they're desaturating, how quickly they're recovering once they've sat down. The portable SATs probes were a lifesaver because we could kind of see as we were going and you know, if we needed to stop, take a breath, whatever. We were finding that sometimes we're having to increase their oxygen to mobilize because they were desaturating so much that we had to kind of pre-oxygenate them. I think that's fine. You can just leave it there. Thank you. So we were finding, yeah, we're having to increase their oxygen for mobilization to reduce the amount of desaturation we were getting. You know, sometimes we were finding these patients were desaturating quite a lot lower than we were used to seeing people desaturate, and they were taking some time to come up. So it was about, you know, checking their SATs as we were walking, increasing their oxygen before they were walking, and when they sat down, putting them in these positions of ease, trying to get their breath assist back and get their SATs back up to normal. Exercise plans were really important. Obviously, we wanted patients to be doing, we was really trying to promote some kind of independence in their recovery. So we were giving them chair and bed exercises to do between the sessions where we were coming to see them. Just so that they were maintaining that, because say we come and see them for sort of half an hour in the morning, that's a long time for the rest of the day until we saw them next in the afternoon that they weren't doing anything. So we were able to give them these chair and bed exercises to do between sessions. And also if patients were finding that, you know, if they were on the CPAP or on too much support with the CPAP and Optiflow, to be taken off of that to mobilize, these chair and bed exercises provided that chance to do some mobility and rehab without having to take them off that support. Cycling, so we were actually donated a few chair bike pedals, which were brilliant. We were donated them by a patient actually, and we were finding that these were people on high amounts of support and can't mobilize away from their bed space. This provided an opportunity for them to be rehabbed and to be mobile at their bedside. We were also using it as a second session, so we would go and walk them on the oxygen in the morning, and in the afternoon going up to them, giving them these bike pedals just to do something. Like I said, you know, a lot of these patients were very breathless, very fatigued, so we couldn't do too much in one go. So we found that breaking the sessions down into, you know, manageable chunks and seeing them more than once a day was actually providing them with that opportunity to do more. Obviously stairs, when we were getting to the point where patients were ready to go home, we had to assess them on the stairs, but we weren't only using that for discharge. It was actually a way to increase intensity of sessions if we were finding that they were getting quite breathless and we were thinking they needed to go home. practicing the stairs to build up the intensity was another really good way. Discharge planning, obviously these patients were very poorly on the ward. We were having to do quite a lot to rehab them and oxygen wean them when they're quite poorly. That was kind of our focus, maintaining lung volumes, positioning, all that sort of stuff. But eventually, when these patients were ready to go home, we were having to do stuff in the way of discharge planning. A lot of them were off their baseline functionally before they went home, so we were having to ensure they had the correct equipment, aids, and also follow-up. I'll go on to more about follow-up later on. Anxiety management, as I said before, there was a lot of kind of issues around the psychological aspects of COVID, the isolation, the anxiety. I mean, it must be terrifying for these poor people who've never experienced any sort of breathing problems before, to suddenly be so breathless and be requiring oxygen. It was really about the reassurance, and obviously when we're coming over and getting them up, we exacerbate that problem. So there was the anxiety around even knowing that we were coming. So it was lots of reassurance, lots of feedback, some verbal feedback. We were finding that actually the SATs probe sometimes had a really positive effect. If someone wasn't desaturating that bad, they could physically see their SATs and they could take comfort in that. Lots around goal setting. If a patient has a tangible goal that they're trying to reach, it gives them something to focus on throughout the day. So even if the goal is try and sit out, even if the goal is to try and do 10 minutes of prone or 15 minutes of prone lying, any sort of goal really does help those patients look forward to something. Empowering independence, so again, letting the patients take charge of their own care, giving them plans for their positioning, giving them the incentive spirometer to do, giving them the bike pedals to do by themselves, giving them their bed and chair exercises to do by themselves. It really does just promote their independence. It also gives them something to do in the meantime that they can focus on. The breathing control, so we were focusing a lot on breathing control to get the breathlessness back. So we're speaking about the breathlessness management, but the breathing control and also the calming hand were two sort of breathing techniques that we were able to use to try and get the anxiety side of things under control. So breathing control is just the tidal breathing, focusing on your breathing in through the nose, out through the mouth, just really focusing on calming the breathing down. The calming hand is a really useful technique that I found with patients, and it's this hand here. So you get the patient to hold out their hand and you get them to recognize that they're feeling really anxious. You get them to sigh out, inhale gently, exhale gently, and then stretch their hand out as wide as it can go. That usually breaks the cycle of the anxiety, because if we're coming over and the patient's quite anxious, they're already kind of heightened before they've even got up. So that's just kind of setting them off on a bad foot. You want to get them really calm before even starting to get them up and starting to kind of increase their exertion level. So that's a really good way to kind of break that cycle of anxious thinking. Fatigue management, obviously the patients are suffering from fatigue just from the COVID itself, and the fact that they've not been doing as much, so that their tolerance will be less. So again, it's with the pacing, and again the short regular physio sessions, seeing them twice a day in 2 shorter sort of sessions, giving them exercise and breathing exercise in between, so that they're not doing a big chunk in one go, they're able to do it in manageable small chunks and build up that exercise tolerance. Obviously, we want to care for the whole person, so it was a balancing act between mobility, resting to recover, and weaning their oxygen. If you've gone in the morning and weaned down their support from their Optiflow and then expect them to get up and have a walk, it's quite a lot for the patient to do in one go. So it was a balancing act between getting all of the aspects of their care right. Involving family, obviously these families aren't able to see their relatives and they don't know what's going on, so trying to keep the family in the loop via telephone calls. There's wellbeing services and compassionate care team. We're doing FaceTiming for the patients to their relatives, which actually provided those patients with that comfort from home. MDT approach, working really closely with the nurses and the doctors. I know on the respiratory ward, it was just like a really nice team atmosphere, and we were all kind of giving each other advice and doing it together. Also thinking of comorbidity. So obviously these patients are coming in with COVID, but some of them have pre-existing lung conditions. So you want to be thinking about inhaler technique and not losing the rest of the physio that we would normally be doing for these patients. So inhaler techniques and management from that point of view, and making the appropriate referrals for that. onwards after then they've kind of going home. Resources, we had to kind of quickly create some resources and that sort of feedback for those patients to be able to do stuff by themselves. So we formulated a few leaflets. We've got our active cycle of breathing technique leaflet, we made a proning leaflet and a breathlessness management leaflet. We also had the COVID-19 diary and handbook, which we were primarily using for our ITU patients, but it did have some really useful stuff for our ward patients as well. And they're all on our trust net, so that any therapist in the hospital, any healthcare professional can print it off and give it to the patient so that they can read through that and kind of do it by themselves. Just giving them that information and that feedback, because it's very easy, you know, if we go and tell them to do their proning or to do their breathing techniques in the morning, they get so much information and it's so overwhelming for them. We don't expect them to remember it all. So we wanted that kind of feedback for them to be able to go back to it later and think, oh, what did that person say again? And to be able to do that by themselves later on. Onward referrals primarily were to hospital at home team for chest monitoring and SATS monitoring. So that's our virtual ward who can go out and see these patients in their own homes. Then you got the COVID virtual ward in primary care, like as Dr. Khan said earlier about the GP and monitoring their SATs. Pulmonary rehab had a long COVID group. So this long COVID group is very new. It's just the same as a referral to pulmonary rehab, but you can do it because the patients had COVID and still suffering symptoms. Obviously, the patients are, like I said earlier, functionally off their baseline, referring to community physio services. For those with the pre-existing lung conditions, you might want to be referring on to their community matron and community respiratory nurses. Sometimes, you know, if patients have to go home on LTOP because they've got that pre-existing lung condition, that's what we were having to do in some cases. So, last bit on long COVID. From a physio point of view, what are we seeing? It's the persistent cough, it's the fatigue, and it's the ongoing breathlessness. Obviously, as I work in sort of primarily in the hospital, I've not had so much to do with the ongoing management of the long COVID patients once they've left the hospital. But what's being done is there's been the formulation of these long COVID clinics. I think there's 69 across the country so far, and it's a real MDT approach to formulate a personalised rehabilitation and management plan. The occupational health physio here is running long COVID sessions for staff, and as I said, pulmonary rehab are doing a long COVID group, which we're able to refer into, which is really good, and that's sort of about fatigue management, breathlessness management, and that persistent cough. Again, setting these patients up who are going home who still have some symptoms or the long COVID with their self-management, so the breathlessness management, the fatigue management, and the pacing. I've dropped a little link there at the bottom around the guideline for the long COVID and the NICE guideline and what they're recommending. So that's it.
Thank you so much, Charlotte. You filled that in quite nicely. It's just fantastic that we're giving everybody a chance to see how, as a multidisciplinary team, we work together to achieve the same goals. And what you do as a physio is very specific, but it's feeding into the care of that one particular patient, whilst, for example, Dr. Khan is doing his part and the nurse are doing their part, but we all have one objective to ensure that we are ensuring the patient is getting the best level of care and personalized care. That's one thing I like. You sort of mentioned that about ensuring people, you're taking consideration any comorbidities and not just enforcing any plan on them, but in taking into consideration who they are, what they've had done, and what's happening in their lives and what they can actually do. So I think that's quite fantastic. Oh, fantastic. We've got Kim online. Thank you, Patrick. Kim, are you ready? Kim?
I'm ready. And now my dog's awake.
So to my fellow nurse, Kim, take it away.
Okay, so I'm going to be talking about patient assessment and common signs of deterioration in COVID patients, the different oxygen delivery devices that we can provide, and any other important aspects to consider when nursing our COVID patients. So firstly, how do we assess and what are the key signs of deterioration in COVID patients? So patients who deteriorate without recognition or timely intervention are obviously at risk of critical care admission and increased morbidity or mortality. So the best way to prevent this, really, I feel, is just to get to know your patient and their condition. A thorough head-to-toe assessment is obviously essential and can lead to better outcomes for your patients. When assessing any patient, obviously a simple question such as "how are you" can provide significant information. Patients who are only able to speak in short sentences or with 1 or 2 words at a time, sorry, my dog, are usually in some form of respiratory distress, and failure to respond is a very clear marker of serious illness. But there's obviously many systematic approaches to assessment that can help us determine a deteriorating patient. One being the ABCDE approach, which helps us identify any life-threatening conditions in order of priority. So that being airway, breathing, circulation, disability, and exposure. As a part of that assessment, we use a track and trigger tool. Within our trust, we use the scoring system called the National Early Warning Score. So this is based on 6 physiological parameters, that being the respiratory rate, oxygen saturation, if the patient is receiving any supplementary oxygen therapy, systolic blood pressure, pulse rate, level of consciousness or new confusion, and body temperature. At the point of initial assessment, it's always important to attach your simple monitoring tools such as your pulse oximetry or your ECG monitor, and obviously your non-invasive blood pressure cuff. Just good to add, just to go back to the pulse oximetry, although it gives a good indication of oxygenation, it doesn't measure how adequate the ventilation actually is. So a normal saturation is not a full evidence that a patient's breathing pattern or depth is actually adequate. This can only really be determined by an arterial blood gas analysis. So of course, throughout any assessment, it's crucial to consider whether you need any help. Although the new system can trigger a response once it's complete, sometimes their vital signs can still be normal, but obviously as nurses, sometimes we get that gut feeling that something isn't right. You know, vital signs are normal, but they look grey, they're clammy, they're sweaty, they're shaking. So communicate and highlight any concerns as soon as they arise. Widely used across the UK are rapid response systems, which has really been effective, especially during the pandemic. There are different models that exist, but within our trust, we have a nurse-led critical care outreach team and a medical emergency team that support the care of the critically ill patients on the ward. In the same way, I think it's really important at the moment to provide early recognition and referral of patients to the intensive care team. I don't think there's no harm in premature escalation, because if this patient was to deteriorate, like Dr. Khan said, it can happen in a matter of hours. At least they're aware of this patient and you can move forward with that. Many patients who obviously are acutely unwell have abnormalities with their breathing. So you have your symptoms of breathlessness, signs of increased rate and an altered pattern of breathing, and a decreased saturation levels. These are the most common clinical presentations of our COVID patients. And then this typically initiates the need to start oxygen. Which leads me on to my next slide of arterial blood gases. So an arterial blood gas analysis looks at a patient's oxygenation status and acid-base balance. It helps to assess respiratory failure and its severity, and any acid-based imbalance in a critical illness. Now, ABG interpretation can be quite difficult to grasp, and I'm still trying to get my head around it. But even if you understand like the mere basics of it, this can help you prevent and detect to improve patient outcome. So looking at the 5 main components of the arterial blood, we've got the pH or the acid-base balance. This shows us how acidotic or alkalotic a sample is. Significant or even a small change in pH can indicate life-threatening problems that must be treated rapidly. Next, you have your CO2. This is used to assess ventilation. So this can help us determine if your body is able to rid itself of carbon dioxide appropriately, and or if carbon dioxide is being retained by the body. Next, you have the PO2, which is used to assess oxygenation. You've got your bicarbonate, which is a vital component of maintaining acid-base homeostasis. Low bicarbonate levels in the blood alongside a low pH can be a sign of metabolic acidosis and can also indicate issues with kidney function. And then lastly, we have oxygen saturations, which are measured on a scale of 100, and this can indicate how much oxygen is making its way to the tissues of the body. So what might we look at in relation to our COVID patients? Obviously, with the symptoms that I mentioned there, I think really your first question when looking at an ABG should be, is your patient hypoxemic? Hypoxia is the most immediate threat to life. So we're looking at a normal PO2 should be greater than 10 kPa when oxygenating on room air in a healthy patient. If a level is less than 10 on room air, a patient is considered hypoxemic. And if a level is less than 8 on air, patient is considered severely hypoxemic and in respiratory failure. This is classed as type 1 respiratory failure. Furthermore, if a patient has a combination of a low PO2 and high levels of carbon dioxide in their blood, so a level greater than 6, this is known as type 2 respiratory failure, although this is not as common in COVID unless they're really, really tiring. We can also look at any electrolyte disturbances on an ABG, so we can look at sodium levels, potassium, chloride, and calcium. So if we have our deteriorating patient with an abnormal ABG and you would need to initiate oxygen, we need to think about the key important aspects to consider when we're using oxygen. That's the next slide. So oxygen, of course, is a drug, and like all drugs, it has its advantages and side effects. Therefore, safe administration is key. Giving too much oxygen can be harmful to the body. Therefore, it's quite important to use a lower concentration of oxygen first. That will achieve the desired clinical effect, and then we can increase where necessary. So the current recommended target range of oxygen saturation for acutely unwell patients who are not at risk of that carbon dioxide retention is 92% and above. For patients with any underlying lung disease, such as COPD or pulmonary fibrosis, this range might be lower at 88 to 92. So moving on to the oxygen delivery devices. As we are all very much aware, the majority of patients who become seriously unwell with COVID require some form of oxygen therapy and non-invasive respiratory support. There is a wide range of oxygen delivery systems available that are capable of delivering concentrations up to 100%. Just the next slide, sorry. Thank you. So starting with nasal cannula on the left there, this can provide 1 to 4 litres per minute, delivering around 24 to 40% of inspired oxygen. These are really easy to use, they're low cost and are typically well tolerated by the patients as it allows them to eat and drink as normal. However, these can become easily dislodged, say in the night, so it's important that you still monitor your patients. And actually the higher flow of oxygen that you use, it can become quite uncomfortable for the patient and cause drying of the nasal mucosa. Secondly, in the middle here, we have the Venturi masks. These are colour-coded masks, which provide an accurate concentration of oxygen ranging from 24 to 60%. Now, these are really useful for patients at risk of carbon dioxide retention, as regardless of the patient's rate or depth of respiration, the amount of inspired oxygen remains the same. And then next we have humidified oxygen. Settings of this are similar to that of a Venturi mask, where they range from 28 to 60%. It's sterile water that is humidified, and this can be beneficial for things like secretion clearance and dryness of the airway that you might get with a Venturi mask. Next, we'll move on to more of your moderate to severe cases where you would use a non-rebreathe mask. These are typically used in emergency situations, as they provide the highest concentration of oxygen, so 15 litres per minute, roughly about 60 to 80% of inspired oxygen. This mask has a reservoir bag beneath it with a one-way valve that prevents the exhaled gases from entering the reservoir bag. Use of the non-rebreathe mask should be monitored closely. Once your patient is stable, it's really important to reduce the oxygen concentration to maintain target saturations. It's really important to remember that over-oxygenating your patient for a prolonged period of time can actually be quite harmful. So as soon as they're stable, after like a medical emergency and they're stabilized, bring that oxygen back down to the Venturi or nasal cannula. Next, we move on to the high flow nasal oxygen. So we use the OptiFlows. This has become an increasingly popular therapy for COVID patients with hypoxemic respiratory failure. It's designed to deliver up to 100% of oxygen with a flow rate of 60 litres per minute that is heated and humidified via nasal prongs. So the benefits of this is that it reduces something called a dead space, so therefore reducing the volume of inhaled air which doesn't take part in gas exchange. So we're overall improving ventilation and oxygenation. It also provides a low level of PEEP. So PEEP stands for positive end expiratory pressure. This pressure is applied at the end of each breath to recruit the alveoli, again, improving oxygenation. And most importantly, with the high flow nasal oxygen, it's been associated with a decreased risk of intubation. And then lastly, in the most severe cases of COVID, we have the CPAP. Now, in the first wave of COVID, we were using this probably maybe too soon, when we could have maybe relied more heavily on the high flow oxygen. So unfortunately, patients were becoming quite dependent on that and weren't able to come off of the mask for prolonged periods of time. Unfortunately, that's when they were taken to intensive care. So now that we've learned in the second wave to, as I said, rely more heavily on the high flow oxygen, the OptiFlow, alongside the pronin and medications to help with any anxieties and things like that. So CPAP is continuous positive airway pressure, and it supplies a constant fixed positive pressure similar to that of the OptiFlow, but this provides it throughout inspiration and expiration. And if delivered with oxygen, it can allow a higher degree of inspired oxygen that any other oxygen masks can provide. The aim of CPAP really is to kind of offload the work of the respiratory muscles to enable you to kind of relax as such. And it recruits more lung volume in order to improve gas exchange. However, with the use of CPAP, it is contraindicated in some cases. So if your patient is confused or agitated, if they have any facial burns or trauma, or they're vomiting, or they have any excess secretions, this is going to increase the risk of aspiration, so you wouldn't use it in this case. So next slide. So what else can we manage as nurses? Obviously, Dr. Khan went into multi-organ failure. As we know, with the inflammatory response of the body, coupled with the direct effect of COVID on body-wide organs, it's been associated with complications of the disease. So renal issues, AKI, gastrointestinal issues, diarrhea, nausea and vomiting. So really acknowledging those comorbidities and potential organ injuries throughout the course of looking after your patient can really manage the patient better. So how can we do this? I guess it's just kind of early detection of any irregular signs and symptoms again, continuous monitoring for your vital signs, ECG monitoring, regular lab tests, monitoring those blood glucose levels. That's really been quite a big issue with our patients because they're on the high dose of steroid therapy. This is predisposing them to hypoglycemic crises such as diabetic ketoacidosis. So it's really, really important to monitor them 4 hourly or more regularly if required. We can also look at things like the fluid status, strict intake and output, making sure they're not in any deficits, or if there's any excess. You might want to administer intravenous fluids if appropriate to maintain that blood pressure and cardiac output. Basic things like monitoring the bowel charts. And something that's quite important as well, obviously, we need to discuss their treatment limitation decisions. So has the patient got a do not attempt resuscitation decision in order? Are they a candidate for intensive care? Should this patient be on end of life care plan? It provides us with good information if and when things were to deteriorate. We've already discussed ABGs. So lastly, I guess other important aspects to consider, nutrition and hydration. Sorry, next slide. Nutrition and hydration has obviously played a huge role in the body's response and recovery to COVID, and especially during the more critical stages of COVID, significant issues arise such as weight loss, appetite loss, reduced appetite because of the altered taste or loss of taste and smell, reduced mobility because of their breathlessness, and a high percentage of the patients that actually get intubated experience dysphagia, so swallowing issues. So if you intervene in good time through screening and the use of multidisciplinary team, this can prevent further skin breakdown, weight loss, and improve any depleted muscle mass. I think it's important really just to find out what your patient prefers, monitor food and fluid intake closely, and weight, like I just said. Consider the use of energy and protein supplements. Little and often really goes a long way. Patients haven't got the energy, patients really haven't got the energy to eat big meals. So like I said, little and often, like jellies, ice creams, biscuits, things like that really are helpful. Although some patients are still able to eat and drink normal, it's unlikely that they're able to meet their full requirements. So we might need to consider something like a nasogastric feeding tube to really help with them. So also mouth care is really important. Sometimes that can be neglected. So it's really important to maintain oral cleanliness to prevent any additional infections and reduce the likelihood of developing bacterial pneumonia. We're really lucky in our trust to have a fantastic mouth care nurse, and she's come up to the ward and advised us how to best care for our patients and whatnot. Also, pharmacological support is important. So obviously, patients with COVID have experienced many symptoms like breathlessness. So initial treatment should obviously focus on the underlying causes of the breathlessness. However, obviously as the disease progresses, we want to focus on treating the symptoms. So use of opioids such as morphine given by the mouth or injected has really helped to relieve those symptoms. Any anxiety medications such as lorazepam, and the list would go on. Really, I think it's just treating your patient as a whole, really thinking about that different areas that can really help your patient. Psychological support, as Charlotte mentioned, we're really lucky again to have our compassionate care team, which has helped us communicate, our patient communicate with the family. Any spiritual needs, so again we've got a hospital chaplain, which can help our patient, even if it's not related to faith, just that time to talk to someone. And again with us, I think it's communicating with the family. I know it's really difficult with our patient load to have that time, but even a brief conversation can really go a long way, and it takes that pressure off the patient. You know, they don't have the energy to speak to however many family members, you know, so I think that's a really useful thing to remember. And I guess last but not least, always follow good infection control measures to protect yourself and your patients. Follow good hand hygiene, dispose your gloves and aprons. Remember, obviously it's one patient use, sharp safety. And within our trust, we've kind of minimised visitors coming in just to protect everyone, really. So, yeah, that's the end of my presentation. Thank you.
Thank you so much, Kim.
You're welcome. Sorry about the dog in the back.
No, it's all right. We will have dogs, we'll have children, we'll have partners coming up, so it's expected when we're conducting this over Zoom. So we do have quite a few questions. I might just sort of take us back in terms of a snapshot, because I'm aware we've had a few people come in, so they might have missed out some of the other talks. But just to sort of put it all together in context, Dr. Khan spoke around the medical management of COVID, and the three key things to take away in terms of management is that the patient needs to have about 4 things in place: an anticoagulant, so whether it's enoxaparin or some sort of low molecular heparin. Secondly, some sort of steroid, which is an anti-inflammatory. So we tend to use a lot of dextromethasone, but there are other steroids that you can utilize. Thirdly, oxygen therapy. And as we've heard from both Kim and Charlotte, that people have to remember that oxygen is a drug. So don't just whack it on because it's oxygen. It is a drug. It does have some contradictions. And Dr. Khan spoke about tocilizumab and baricitinib. I think Charlotte mentioned that there's only been 2 people who have been on the trial this past couple of months because our numbers of COVID are going down. So those are the 4 key areas that he touched around with regards to management. And to remember that there are 3 stages within COVID: the early infection stage, the pulmonary stage, and the inflammatory storm that he talked about, where I think tocilizumab and I can never say that word, so forgive me, where those 2 particular drugs tend to work in that area. And Charlotte gave us a fantastic insight into what physio does. So the physios do a lot more in terms of helping the patients to ensure that they are managing their physical aspects when it comes to COVID. So with regards to breathing, with regards to movement, and they work very closely with the whole multidisciplinary team. So I think everything that everybody does is interrelated. And Kim just summed it up nicely. As a nurse, I think that the nurse draws everything together, being the key person in terms of point of care. So running the labs, making sure that they're on point and making sure that they are keeping the patient within the targets that are set. So if it's to meet certain levels with oxygen, whether it is to ensure their urine output is all right, it's whether to ensure that the blood glucose levels are on point. So the nurse's role is to ensure that what has been set in terms of a plan for the patient is that they're actually monitoring that and keeping that. And if anything goes out of whack, then you are rushing around to make sure that you bring them back to the baseline. So lots of questions. Where do we start? Firstly, I think, Kim, you spoke about blow as you go. Somebody asked, can you just show us how to do that when you talk about breathing and you're talking about blowing?
That was Charlotte, Salah.
Oh, Charlotte, yes.
Yeah.
Charlotte, blow and go. What does that look like?
So blow as you go is a way of pacing your breathing as you're walking. So we try and ensure that patients we time it to their breathing, but for an example, we would say breathe in for 2 steps. So as you walk 2 steps, you would breathe in and then breathe out for 4 steps, because obviously normal breathing pattern, you breathe out for longer than you breathe in. So we just try and time their breathing with their stepping. So it kind of takes their mind off the breathlessness because they're having to think about their breathing, but it's a really good way of pacing their breathing to reduce the amount of breathlessness they're getting when they're exerting themselves.
Okay, thank you very much. So for long COVID patients, this has been a topic around prophylaxis. A lot of people are taking medications to either protect themselves or after they've had COVID. There is one around blood clots. So some patients are being prescribed aspirin to manage blood clots for about 2 months after they've had COVID. Is there anything else that they can take if they are having adverse effects to aspirin?
So the jury is still out about post-discharge thrombosis. What we're doing is, if a patient has had a protracted stay with raised D-dimers and we are concerned that they are at risk of prothrombosis, the British Society of Haematology advises 3 weeks of prophylactic fragmin, and that's it. We were giving higher doses and we were giving longer duration up to 12 weeks, but that's now being counseled against. I think the reality is we just don't know.
Okay, that's fine. So in terms of positioning, we saw several ways that we can position patients to ensure that they get maximum breaths in, so they're getting the gaseous exchange that they need within their lungs. Personally, from my from working critical care, we are seeing a larger number of people who are coming in who are obese in terms of the weight categories. And I know that even in the communities like the nursing homes, or if people go into home care, and now because of the vaccine, we are seeing less people being hospitalized. They're still getting COVID and managing at home. Now, the question is, if you've got a patient who is overweight or obese and they have a chest infection, how would you recommend that you position them in the hospital setting, and how should they position themselves at home?
So in terms of positioning, it obviously depends what they're presenting with. If they're having secretions and that was primarily in a certain area of their lung, then you could position them so that it drains from that area. Again, if you've got a larger person, being on their front or being upright, anything that offloads that abdomen from their lungs is the best. But it depends what they're presenting with and what's their main kind of issue. If it is the secretions, then you might want to drain them. If it's to do with the COVID and the low saturations, and you're trying to do VQ matching, then you might think about putting them on their front, or anything that's upright. We really want to avoid these kind of slumped postures, these lying on their back postures.
Okay, so you still would want to position them on their front. You'd still want to prone them. I think just taking consideration, let's say they might have a larger circumference around their middle, and you are positioning them on their front.
Then I would go for the side lying, or upright. Okay.
Thank you very much. Now I'm gonna read a statement that was given to me. There is a question at the end of this. We've got someone who has had COVID, and it seems they might be suffering some post-COVID effects. So what they said is that they had the virus end of March last year, which lasted about 18 days, and they lost their sense of smell, taste, and appetite, and had problems with breathing, severe fatigue, unable to walk, unaided, dizziness. Just to put this into context, this would be a middle-aged female in about early 50s, maybe a BMI of about 30, 31-ish. And they also had things like nausea and vomiting, and that lasted for about 2 months until they recovered. Afterwards, what this individual started to notice is that although their sense of smell and taste returned, their senses were confused. Where, for example, they would love onion and garlic, now it would smell like eggs. So it's like their smells and taste got confused. And they are now having bouts of chronic fatigue. So performing small things like walking or going up the stairs is making them feel dizzy, lightheaded, where they feel like they need to collapse. They're feeling hot all of a sudden. So the question is, how long do these symptoms last for? And is there anything that can be done about it? So this is someone, it's been literally 12 months now, about a year.
So I think this is for me. Again, our experience is that on average, symptoms can last for weeks to months, and what we normally recommend is about 6 months. But it also depends upon the post-recovery rehab program that the person has undergone. And COVID is more than just a respiratory acute lung injury. It affects patients physically, but also psychologically and mentally as well. And how their recuperation has to include that aspects of it as well. The mix-up smells I can't explain. It's a bit too far above the diaphragm to fall within my area of expertise. But we do know that patients have had significant neurological sequelae as well. Tingling, peripheral neuropathies are quite common with COVID-19 as well. With regards the tiredness and the fatigue, my question would be is, did they embark upon a form of rehab following their illness? We know that there is some patients do more rehab, others do less, and that does have a consequence as well. The BMI is a fact that that also has an impact as well. Lastly, is the question that I probably, as a respiratory physician, I would like to ask is this fatigue which is causing tiredness and breathlessness, or is this hypoxia that is causing breathlessness? And so the only way I could answer that is by doing a thorough assessment. And these are the sorts of patients that we would bring back to our clinic, do chest x-rays, do lung function tests, do shuffle walk tests. And actually, in hindsight now, maybe I know we've had brilliant presentations from Kim and Charlotte, but maybe we could have included a talk from our physiologist who runs our lung function lab. That might have been, just rounded this sort of multidisciplinary approach quite nicely. Sorry, I can't give you a quick answer or a quick fix answer. But yeah, I think maybe see your local friendly neighborhood chest physician.
So what I'm getting from your answer is make sure you get a thorough checkup, involve a physio, involve somebody that would look at your chest and have a plan in place. I think from what Charlotte was saying, have some goals that you need to achieve to ensure that you're meeting those goals in terms of your rehab and care. Is that right?
Yep,
in
that's
a
correct.
nutshell?
Yeah.
Okay. Okay. Fantastic. Another question around the virus. So I know that in Wuhan, they had started seeing people getting COVID-19 again, people who have had COVID previously getting it again. Now, the question is, if my symptoms, an individual symptoms were bad the first time round, and then they get COVID again, will the symptoms be milder?
Again, just don't know. The evidence is not out there. I think it's a case by case thing. As I explained, I sort of alluded to in my talk, the phenotype, and I don't have a better word than phenotype, meaning the presentation, the symptoms, the sort of presentation, the population of people who are affected, BAMI, male, female, etc., etc. What we saw in the first wave was diametrically different to what we saw in the second wave. We know that the Kent virus, which started up the road in Canterbury, so not in Dartford, has a higher R number and more patients were affected, and that's why our second peak was 73% higher than our first peak. I wish I could give you glib and short answers rather than sharing my ignorance. But yeah, just don't know. I think treat each individual epoch and treat each individual person on a case-by-case discussion. So as I sort of alluded to, stratify them, get the drugs in that we need to get into them, the bloods, the chest x-rays, if we need CT scans, all of that.
Okay, thank you. I think it was Kim who said there's something about diabetes, something about because in the treatment of COVID, high doses of steroids are being used, that messes up the balance with regards to your blood sugars. Are you seeing a lot more people coming in with possibly diabetes problems with their blood sugars after they've gone home and recovered from COVID?
Again, I'd struggle to give you an evidence-based epidemiological answer because we're still just coming out of the second wave, and so my patient mix that I'm seeing are generally the sicker patients, and so I'm not getting involved, and I won't be able to give you a feel for that either. And looking at the literature, yes, we know COVID and hyperglycemia and diabetes there is some well-reported literature, but if you're asking for my personal experience, I wouldn't be able to answer.
Okay. All right. Now this is a question on vaccines. So once I'm putting a disclaimer on this one, so I'm asking for opinions or thoughts around what do you think, what will the vaccine actually do in the bodies of those who have already suffered from COVID-19? So they might have some levels of antibodies because they would have recovered from COVID, and now they're having the vaccine. Have you heard anything, or are you aware of anything in terms of how they are responding to the vaccines?
So there's good evidence coming through both in the UK and in Israel, because obviously, as you know, the recommended intervals between the two doses was 3 weeks. In the UK, it was extended to 3 months plus, so that more patients could get the first dose rather than patients getting both doses at the same time. But the evidence coming through is that it's like an immunological booster. I'm always cautious talking about vaccines because I'm not an immunologist, and so that's my understanding. There's lots of conversations about the AstraZeneca vaccine. There's been lots in the press about the thrombosis risks from the AstraZeneca versus the Pfizer. There's some good evidence coming through about mixing vaccines. They're using the Russian Sputnik vaccine with the AstraZeneca vaccine. There's no evidence so far about the efficacy of delaying the vaccine from 3 weeks to 3 months. And I'm always cautious. I think if I can just bring you back to when I showed you my slide that in October when we were told about the second wave and what reality turned out. I think a lot of things will become clearer with time. Personally, we were offered the Pfizer vaccine. We took the Pfizer vaccine. Other hospitals were given the AstraZeneca vaccine. They took the AstraZeneca vaccine. In the UK, we're limited by what we're provided by our respective trusts or primary care, depending on where you got it from. So there's not a lot of choice in the situation. And I suspect that probably has resonance with other people up and down the country and in different parts of the globe as well.
Okay. I think this is for all practitioners now. Because of the adverse effects that COVID had on the Black and Asian and minority ethnic groups, there's been a lot of questions, and people are trying to find ways to understand how they can identify somebody being in distress. So even as a student, I found this very difficult because I couldn't find any evidence of what respiratory distress might look like in brown or dark skinned people. So are you able to give us an idea? Because I know that for my lighter skinned colleagues, I'm able to say, oh, they're turning blue, they're turning purple, and so on. What would that look like if I'm home and I see one of my family members? How do I recognize respiratory distress? If I can't recognize it physically, what should I be looking for?
Shall I start with this? So,
Yes.
so starting with, so going back to what Kim was alluding to about ABCD. So A stands for airway. Is the patient able to talk? Are they able to talk in full sentences? There's no extraneous sounds, stridulous or wheezing coming out of their upper airways. And B is their respiratory rate. Respiratory rate is a really, really useful marker to tell us about worker breathing, but also depth and symmetry. You're right about cyanosis. I think, yes, in fair-skinned people, cyanosis is a lot easier to notice as well. However, I think if you have someone who's breathing away, because the other thing is in young patients, what they will do is their respiratory rate will go up to compensate for hypoxia. And these patients won't become cyanotic. But if they're chugging away at 25, 30, 35, 40 breaths a minute, that patient is going to run into trouble sooner or later. The third thing is obviously SATs. I mean, SATs now, most Android, well, some of the Android phones have where you have the fingerprint and they have some sensors inbuilt. You can download apps apparently that can monitor SATs. And again, people talk about how inaccurate it is. And what I always answer is that it's the trend that's important. That if your SATs probe on a mobile phone, which is not very accurate, is recording, say, 95, which is possibly low in a teenager or in a young adult, but if it remains 95 and it's not deteriorating, it's probably reliable and it's quite reassuring. However, if it was 95 and it's now plummeting down to 85, that person's in trouble as well. Lastly, obviously, pulse oximeters are now, you can get them quite cheaply. You can pick them up for a few bob on the internet. How reliable they are or not, it's a difficult thing to say. But again, I would argue that the trend is usually quite helpful to giving you an idea. So A, B, and oximetry as well.
Okay, that actually answered the question about how do I check a patient's oxygen levels at home. So as Dr. Khan has said, there's you can do it on your mobile phone. You can buy them off Amazon or in a shop. And I know even in Malawi, people are able to access them, I think, from the game and other shops there. So do look around. And they also tend to also give you a reading for your heart rate. And as what Dr. Khan has said, make sure you have a baseline. So when you do buy it, check what your baseline is over a day when you're normal and healthy, so that when they're out of range either way, then you know that that is what's not normal for you, because what's normal for you would be different for what's normal for me. All right. So what 3 things would you advise? I know I'm just throwing this in. So what 3 things would you advise people to arm themselves in terms of equipment or little kits to look out for? So if with COVID going around, what are the 3 things that you'd want them to check besides their oxygen and the heart rate with the pulsometer? What else would you advise them to get that's cheap and reasonable and can help?
Mask.
Mask?
That's one.
Yeah, fantastic.
Some hand gel or hand sanitizer of some shape or form. And can't come up with a third, to be honest.
Thermometer?
Yeah, I was gonna say that. Yes, a thermometer. Yeah, just to keep temperatures.
Yeah, good
At
one.
what level would you recommend that they say its baseline is normal? And they should be calling an ambulance or going to hospital. What level?
So again, it's so obviously normal range is around 37.2 to 37.6, but some people run a bit hot, some people run a bit cooler. It's the trend. And if you're feeling well, it's like blood pressure. We've all seen patients that, you know, usually petite young females whose blood pressure is scarily low, but they're absolutely fine. So it's about getting a feel for what their norm is. And then if it's just a one-off reading, or if it's just one reading in the context of an otherwise healthy person, probably okay.
Okay. I'm just going to throw this out to the audience. If anybody has had the vaccine, so is there any evidence to suggest that those who have had the virus and then decide to have the vaccine in the pre-allocated time over the 4 weeks, that they do have side effects? Would their recovery from the vaccine present longer symptoms? Would it take them longer if they show any side effects, recover from those side effects?
So the evidence is still being accrued from all the trials following the vaccines. From personal experience, both times. So I had COVID last year, and with both times I had the vaccine, for 48 hours I was unwell, and I was back on the paracetamol and the ibuprofen and hot tea. But I've also had colleagues who never had COVID, who had similar side effects following the vaccine. So again, apologies that I can't give a clearer answer.
No, that's fine. Like you said, once again, it will be different for different people. And once again, if you have underlying conditions or if you have any allergies, please do contact your GP, health practitioner, and speak to them before getting the vaccine. So if you need any advice, speak to a health practitioner around that. Well, I think you answered this question. If there's any evidence that show that Black and ethnic minority people are suffering more from post-COVID virus, I think you said that in the second wave, what we saw in the first wave is not happening again. It's different now, isn't it?
Yeah, and one question you have to ask yourself, I'm not a big believer in conspiracy theories, but I think that's a question worth asking, that was there more awareness about PPE? And I just don't know. I really don't know. I think my experience was first wave, there was just a lack of discipline and diligence with regards to PPE across the board, lack of availability, lack of good practice. And was that a factor why BAME patients were more adversely affected? Okay. I just don't know. But yeah, I think there has been a changing phenotype. Yeah.
Okay, thank you. I'm looking at the time. I know we started about 5-10 minutes late, and I'm trying to stick to time. I'm just going to read one of the last comments that was written up there, because I think I've covered all the questions, unless Charity has picked up any. So this is coming from a lady saying that she's an identical twin, and both her and her twin had the vaccine. She had good recovery, whilst her twin took a little bit longer, but her twin actually had COVID. So these are identical twins. I know them. They're very, very identical in everything. So it's good to sort of get that sort of understanding that if one might have had the vaccine, that's how they've responded, because they've had COVID and they didn't have COVID. Just as an example. So somebody said, how do you recover from the loss of smell post-COVID?
Time. Eat lots of yummy food. Eat lots of yummy food. Don't talk about food. I haven't had
So-
lunch today.
Okay. Oh, okay. On that note, I am going to pass it on to Charity, because I think we have covered all the questions there, and I am weary of aware of the fact that it's a Friday and you've all taken time out to spend with us. So we really, really appreciate that. Charity?
Oh, thank you, Sarah.
Oh,
Thank you, everyone.
Okay.
Can you hear me?
Yes.
Great. Okay. It's an honor again to have you all here and to be entrusted with such an undertaking to close this webinar. We've had such passionate individuals. Dr. Khan has come again. This is the second time with us, Malawi and UK Nurses Association. And your team, it's absolutely great to have you here. This webinar has been an outstanding example of multidisciplinary working in COVID. Dr. Khan, Kim, Charlotte, you just made it seem easy, but loads to reflect upon as we contribute and enhance our individual and collective knowledge to combat this disease globally. Some of us are aware of the challenges that we face in Malawi, and I'm glad someone asked about how do you recognize respiratory distress in Black or brown people, because most of us in uni or colleges or in school, we learn about cyanosis and not typical of what presents in dark-skinned people. And you answered it so well. It sounded so easy when you said just A, B, C. And listen, those are just the basic stuff, isn't it?
Okay. Charity, you've frozen a little bit. I know that Charity has been having some issues with her IT.
Team.
Charity, are you back?
To all our speakers, our colleagues on the ground, your presence is invaluable. Without any doubt, you making Muna's webinars a success. I'm sure we have all benefited from this webinar, and we've taken a lot of numerous points, which we will share with our colleagues. So thank you so much again. And thank you, Sarah, for moderating this very well. And thank you, the executive team of Muna and all those working in the background, Sarah Aman, I've seen Dr. Shimota, he was here as well. So thank you so much, everyone.
Thank you, Charity. I mean, once again, a massive thank you to Dr. Khan, to Charlotte, to Kim, for taking time to come to speak to us today and giving us all an insight of what it means to work as a team to achieve one collective goal, and that is to ensure that we're caring for a patient with COVID-19 in the best possible way and giving them the best chance to combat that illness. So I just wanted to bid you all a good night. Thank you all so much. To remind you once again, we are recording this and we will be sharing this on our YouTube page, and we'll put it up on our website. So give us some time, do bear with us. Thank you very much, Charity. For
I can see Charlotte's hand.
Oh, Charlotte, you've got a statement, a question.
Yeah,
Charlotte.
Yeah, can you hear me?
Mm-hmm.
Yeah,
Yes, I can hear you.
Before you close, I just wanted to say, as Muna, one of our objectives is to raise funds and buy some essential equipment for our hospitals in Malawi, because from all the presentations that we've had today, we don't really have most of the equipment that have been mentioned. And I'm sure most of the patients who have actually died in Malawi, they could have benefited if we had even a simple NIV machine or a blood gas analyzer. We don't have those back home. And the oxygen that we have at the moment is just like non-rebreathe masks and nasal prongs, which hearing the presentations today are not really very effective when it comes to looking after patients with COVID. So I just wanted to say, put it out to the audience that we are trying to fundraise to see if we can buy some equipment for the hospitals in Malawi. So maybe before we go, Sala or Patrick, you can put our account details in the chat. So if anyone would like to sponsor us or to donate anything, you are very welcome to do so.
Thank you very much for that, Charity. Just to remind you all our speakers are doing this in their own time. They're volunteering. We're not paying them anything. We don't have anything, but we want to just say thank you to them for volunteering their time and their expertise and sharing that with us. And just to echo what Charlotte has just said, yes, we are raising funds, and I'm asking Patrick to please share our GoFundMe page and our account details. We will share them. I think we've got a lot of people's emails. We will probably send out an email and share those details. And we would welcome you to support us to help get the equipment that can help our brothers and sisters back home in Malawi to manage COVID, because we don't even have enough ventilators. It's about 20 in the whole country. So 20 ventilators for the whole country, that is absolutely nothing. So looking at managing COVID on the wards with equipment that's easily accessible up here is what we would like to help and assist with back home in Malawi. So this is just a call out. Thank you very much. But once again, massive thank you to everybody. And I hope that we will see you again. We'll be having more webinars. And I think Dr. Khan alluded to somebody getting somebody in from the multidisciplinary team that looks at lung functions within the community. So that's something that we can look at, isn't it, Charity?
Oh, yes, definitely. We'll take
yes.
it.
So every time we have Dr. Khan on, he always brings something up and we have to have another webinar. So thank you very much for that, Dr. Khan. And thank you everybody for coming in tonight. I hope you have a good night. If you have any questions, any comments, please put it in the chat. We're going to leave this open for another 5 or 10 minutes. If people just want to chat and say good night, that will be fine. You can unmute your mics. It's a free for all from now on. Thank you, everybody. Have a good night.
Thank you. Thank you, Sarah.
Zikomo.
Good night.
Thank
Good
you.
night.
Good night, everybody. Thank you. Thank you, Dr. Khan. Thank you, Charlotte and Charlotte.
Thank you.
Thank you, Salah.
Oh, hello, Gladys. Thank you for coming in.
Bye.
Thank you. Oh, we've got Tekla. I'm looking at
Bye.
people's
Bye.
names.
Thank you.
Thank you so much.
Very wonderful information.
I'm glad. We're glad. That's the important thing.
Yeah.
Fantastic. Patrick has just shared the details if anybody wants to take them. Thank you so much.